Good morning. My name is Alejandra Isabel Castillo Cervantes. I am resident from the first year of radiology, and today I'm giving my interesting case. The history of this case is a 33-year-old woman with a history of volume increase of the right knee. She went to the traumatologist, and he sent her to take some radiographs. So here we have the first X-rays. Here we see two X-rays, AP and lateral projection of the femur, where we observe it without any alterations. At this level, we do not see any lesion that explains the increase in the volume. But then we have these two X-rays in AP and lateral projections of the tibia and the fibula, where we can see at the level of the metaphysis, right here, and the proximal epiphysis of both the tibia and the fibula, a lytic expansive lesion that causes increase of the volume of the soft tissues. We can see it here, right here, with a thin recline, with subchondral sclerosis, and without subchondral sclerosis, which is a really important feature of this tumor. And we considered as the first diagnostic option giant cell tumor without being able to rule out chondrosarcoma. They also took some thorax X-ray. Here we have in PA, and we see multiple radio backgrounded images in both of the lung fields. They are generalized and they have bilateral distribution. They have a radiolucent sensor, and within the context of the patient, we cannot rule out metastasis. Well, we concluded that it was a giant cell tumor. The biopsies has not been taken yet, but well, the general features of the giant cell tumor is that it's usually benign. It typically arises from the metaphysis, as we can see here, of the lung bones. The first place where it arises from, or the most common place, is the tibia. And well, it extends to the epiphysis adjacent to the joint surface, as we can see here. And it has a narrow zone of transition. It is really important to remember that the zone of transition is the outer margin of the lesion that represents the change from pathologic to normal bone. So here we can see a really narrow zone of transition that if we have a wide zone of transition, it is talking about that is probably a more aggressive lesion. So the giant cell tumor is commonly benign and it has a narrow zone of transition. Well, 99 to 97 occur when the growth plate is closed. So it is gonna happen in the early adulthood, as the case of our patients. 80% of the cases occur between ages 20 to 50. It has mild female predilection, but malignant transformation is far more common in men. The clinical presentation, it is identified incidentally with insidious bone pain, soft tissue mass, as in our case, or compression of the adjacent structures. They are low-grade tumors. Only 5 to 10% are malignant. Less than 5% have lung metastases. This is why I also thought that it was a really interesting case, because it is uncommon that they have lung metastases. And it has an excellent prognosis. Even though it can give metastasis, it is called benign metastasizing giant cell tumor, because with the treatment, it can have an excellent prognosis. The location, 50 to 65% occur around the knee, in the distal femur and proximal tibia, just as in our case. The second most common place is the distal radius, And then any vertebral body starting from the thoracic spine, then the cervical spine, and then the lumbar spine. And the less common place is the sacrum. If it occurs in multiple locations, it is usually associated with metastasis. And the X-ray findings, the 4 characteristics in the X-ray are that it occurs with a closed growth plate, as we already said, so it is going to happen in young adulthood. Less than 1 centimeter from the articular surface, as we can see here in this image. It is not taking the articular surface, but it is less than 1 centimeter from it. It has a well-defined non-sclerotic margin that we already said that is also a really important feature of this tumor, because the non-sclerotic margin tells us, or it gives us a clue that we're talking about a giant cell tumor and not another pathology that we're gonna see later. That is a differential diagnosis, and it is eccentric, as we can see here and in the other images. It also gives the phenomenon of ballooning, that is a special type of cortical destruction. It is a destruction of the industrial cortical bone, and then a new bone on the outside starts to add at the same time that the cortical bone it is destructing. So it's gonna give some expansion, as we can see here. So the rate of the destruction and the addition of new bone is going to happen at the same time, and this is a phenomenon of ballooning. On the CT, we're gonna, well, the CT is not gonna give us more information of the tumor itself, but it is superior to conventional radiography to outline the tumor extent. What we're gonna see in the CT is as an expanded and thin cortex, as we can see here. We can also see matrix calcification. It's not going to be always present, but it can happen. And we can also see fluid levels that we're not going to see in the X-ray. The fluid levels can be talking about intratumoral hemorrhage. And well, these are the characteristics in the CT. Here we have, another CT where we can delimit, or we can see more the cortex thinning and the breakthrough of the tumor. If we add some contrast, as we can see here, we can see heterogeneous enhancements. The treatment of this tumor is curettage and packing with bone chips or polymethacrylate. 40 to 60% of the cases are going to have local recurrence, and monoclonal antibodies can be used also. The differential diagnosis are aneurysmal bone cysts that occur in a younger age group, and well, they are going to happen more frequently in the metadiaphysis. And they occur also more frequently in the vertebrae. And initial diagnosis is the chondroblastoma that is gonna occur more frequently in the epiphysis without extending to the metaphysis that is gonna that is typical from giant cell tumor, and it also occurs in a younger age group. The chondroblastoma is also gonna have an sclerotic margin. And we already said that the giant cell tumor has a non-sclerotic margin, so this is also another clue to think more of chondroblastoma rather than giant cell tumor. These are my references. That's it. Thank you.
Good morning. My name is Gabriela Salinas. I am second year resident of the Department of Radiology, and I'm going to present my interesting quiz. It's about 45-year-old man present to the emergency department with abdominal pain for 1 day and hematuria, acute weakness with altered conscious state. He had a history of hypertension and diabetes. On physical examination, there was a painful palpable mass located on the right flank, and he developed hypotension with mean arterial pressure dropping to 45 millimeters of mercury and lactic acidosis, requiring aggressive volume resuscitation. Was performed. And we can see it has a bilateral pleural effusion and lamellar metastasis, and this is the more important finding. We can see that it's an enlarged right kidney at the expense of a solid lesion with partial definite heterogeneous edge with areas of greater density. And we can identify a wedge-shaped cortical defect that knows a notch sign, which is then subcapsular. So with that should be considered an angiolipoma with discarding the possibility of renal cell carcinoma. And with moderate size subcapsular renal hematoma. And in the bladder with an irregular image and partially the defined border, and that this is suggestive of clot. And ultrasound was performed. In the bladder, we can observe an echogenic material adhered to the wall with no flow color Doppler evaluation in relation with residual fluid. Due to the worsening of the patient clinical condition, it was decided to opt for total nephrectomy, and this was sent for histopathological study, and then reporting renal cell carcinoma. And with the results obtained by the CT as well with the patient clinic, we can integrate this case in a Wonderlet syndrome. And this is a rare condition in which spontaneous non-dramatic renal hemorrhage occurs into the subcapsular and perineal space. And the clinical presentation is with the LENS triad, which consists of acute abdominal pain, a palpable flank mass, and hypovolemia, but the clinical manifestation can be varied and not specific. For this topic, we are going to divide into neoplastic and non-neoplastic groups. The neoplastic, we have the most common is the Benign, and angiolipoma is the most common, and we can have some we can have the malignancies, and this is the most common, the renal cell carcinoma. And then non-neoplastic, we can see vascular cause like vasculitis, like thrombosis, and renal disease, calculus disease, nephritis, and coagulation disorder. The imaging goals in suspect case of this syndrome include confirmation of the diagnosis by identifying renal hemorrhage in the subcapsular or perirenal space and detecting the etiology of the bleeding. The ultrasound is less sensitive than CT and MRI for detection of the etiologies, but it is highly sensitive for identification of the perinephric hematoma. In particular, attractive in follow evaluation of the evolution of the lesion. The CT is the first image modality of choice, and the etiology of the bleeding is identified in only half of the case of initial CT. The MRI might be performed when the bleeding source is not identified on the initial CT examination, and is useful in pregnant women. The imaging findings of the etiology of this syndrome is very different and will depend on each pathology. It might be due to infections or cysticercal disease and vascular condition, and I will show some cases. This is a case of spontaneous perinephric hematoma in a 35-year-old man presenting with acute right flank pain. A transverse sonogram demonstrates heterogeneous perinephric subcapsular fluid collection, and CT shows an hyperdense subcapsular fluid collection consists with acute hematoma. In this case, we have 49-year-old woman with right flank pain and hematuria. The axial CT image shows pseudoaneurysm in the right renal ileum with a large perinephric hematoma due to the rupture of this. And this case is a 52-year-old man due to renal damage thrombosis. The axial CT shows a near-occlusive thrombosis of the right main renal vein with a perinephric hematoma. This is a case of a 62-year-old woman with fever, left flank pain, and urinary tract infection. And in this CT, we can see image shows the ill-defined hypodense areas with a left renal parenchyma, suggestive of acute pyelonephritis associated with hematoma. And this is another case of a 59-year-old man with chronic renal failure present with right flank pain. In the CT, we can see at the level of the kidneys a multiple bilateral renal cysts consisted with the disease with associated right perinephric and subcapsular hematoma on this level. And in this CT, image show left hydronephrosis, and we can see hematoma. And in the coronal reform, we can see the hydronephrosis and two obstructive stones in the proximal urethra, and associated with a perinephric hemorrhage. In the treatment, if the hemorrhage is self-limited and the patient is responsive to fluid resuscitation, the patient can be managed conservatively. And if the hemodynamical is unstable patient, it can be managed with emergent nephrectomy, like the patient of this case. And in conclusion, the Wanderlust syndrome is an acute emergency with a broad spectrum of etiologies, and the CT plays a pivotal role in identifying the etiology in correlation with the clinical history, and plays an important role in deciding the future course of the treatment. That's all.
Good morning. My name is Natalia Marisela Carrera Flores. I'm a second-year radiology resident and a Centro Universitario Imagen Diagnóstica del Hospital Universitario, and I will present to you my interesting case. Okay, so this is about a pulmonary trauma patient who is admitted after being run over by a vehicle on a high-speed avenue. We didn't know anything about this patient. We only knew that he was a homeless person. He was around his 50s, and he was a male. So he was on a 10 on a Glasgow Coma scale. So a simple head tomography was requested. So first, I'm going to show you the CT. Eso no quiero empezar. Ah, bueno. Déjate para enseñar. Pero quiero poner que sigue. ¿A qué le picaba? No, el otro. Cochlear. Okay, so this was the soft tissues head CT. Then I'll show you the bone head CT. Okay, so this patient had several findings. First, I'll tell you each and every one of it. He had a left maxillary hemosinus associated with zygomatic bone fracture. He had a fracture of the left pterygoid process and a left infraorbital nerve canal fracture with fracture of the lateral wall of the maxillary sinus and the fracture of the frontal process of the left zygomatic bone. He also had pneumoorbital with ocular muscular involvement and fracture of the orbital aspect of the left zygomatic bone. He also had a dislocation of the nasal septum with deviation to the left without conditional mucosal contact. And he also had a fracture of the mandibular symphysis involving the tooth sockets. He also had a left premolar fracture in the maxillary, where the maxillary bone moved forward, the zygomatic bone moved laterally, and the lateral wall of the orbit moved like outward. And he also had a lateral fracture of the lateral wall of the maxillary bone. But what was most interesting of this patient is that in the actual bone CT of our patient, where it shows a corkscrew cochlea with our interscalar septa, and he didn't have a modulus. The internal auditory canal was wide and it merges with the cochlea. Here's another bone CT where we can see the dilated vestibular aqueduct. So we have three differential diagnoses for this cochlear malformation, which is the cochlear incomplete partition type 1, the large vestibular aqueduct or incomplete partition type 2, and the cochlear incomplete partition type 3. First, the cochlear incomplete partition type 1, which is also known as a cystic cochlear vestibular malformation, it is due to a developmental interruption during the 5th week of the pregnancy. It presents itself with a sensorineural hearing loss. It is a congenital sensorineural hearing loss where there is an absent macula cribosa and modulus. And the treatment when the patients have bilateral profound sensorineural hearing loss is the cochlear implantation, which has variable success. The cochlea shows a total absence of the modulus, and it has a cystic appearance, without internal architecture. The vestibule is normally dilated, and the labyrinth as a whole has the appearance of a figure of an 8. In this malformation, we can see the cochlea and the vestibule, which in turn allow us to distinguish from the whole cavity. And the cribriform region located between the cochlea and the internal auditory canal is usually defective. And this wasn't the case for the cochlear malformation from our patient. Then the next differential diagnosis of the cochlear malformation is the incomplete partition type 2. This type of incomplete partition is due to a developmental interruption during the 7th week of the pregnancy, and it is the most common dysplasia of all. It is presented in the 50% of all malformations, and it can be bilateral or unilateral, severe and profound sensorineural hearing loss, or it can be precipitated by minor trauma. Patients can also have vestibular symptoms, and there can be associated with a syndrome that's called Pendred syndrome, that includes hypothyroidism and goiter. It can be fluctuating. The sensorineural hearing loss can be progressive, and it can be not with hearing loss. When the patients have large vestibular aqueduct, they usually are recommended to avoid conclusive-prone contact sports due to the trauma that precipitates the sensorineural hearing loss, and it can also be treated with cochlear implantation. In the cochlear incomplete partition type 2, it can be presented with fusion of the middle and apical turns and a cystic appearance due to a defect in the apical segment of the modulus, the interscalar septum, and the osseous spiral lamina. The modulus basal coil and the basal segment usually looks normal, and it is usually associated with an enlarged vestibular aqueduct and due to the duct and endolymphatic sac dilatation, and with minimal vestibular dilatation that makes up the triad or a syndrome that's called a Mondini deformity triad. That's also a name where you can find the cochlear incomplete partition. They are like synonyms: Mondini triad or cochlear incomplete partition type 2. And this wasn't also the case of our patient. And then the cochlear incomplete partition type 3, it is a recessive genetically inherited disease linked to the chromosome X, and it is not due to a developmental interruption of the optic plateau. It usually affects males, and makes hearing loss of rapid progression. Males are affected, and females are the carriers. Normal or most mild delayed onset hearing loss. It presents itself with bilateral profound sensorineural hearing loss, and it may be or not progressive, and it can also have or not conductive hearing loss. It can have conductive hearing loss from stick fixation, and conductive hearing loss may be masked by severe sensorineural hearing loss. And patients can also have impaired vestibular functions. When it is a profound sensorineural hearing loss, cochlear implantation can be used for treatment, and all patients with IP type 3 have severe gaucher at the cochlear. And this the cochlear incomplete partition type 3, we can see it as a total absence of the modulus, so the interscalar septum is present. The cochlea is located laterally to the internal auditory canal, and that it is in turn wide and both widely communicated due to a complete deficit of the cribus layer. You will identify the incomplete partition type 3 as a rotated cochlea located directly to the lateral edge of the internal auditory canal, with a total absence of the modulus, but with an interscalar septum. And there is also a cruciform plate deficit with wide communication within the cochlea and the internal auditory canal. And usually the the appearance of this the cochlear complete partition is it's like a corkscrew. So this is the case from our patient. Our patient had a cochlear incomplete partition type 3, and maybe he didn't know that his hearing loss was due to a congenital malformation.
Sí, creo que sí. Eso lo conecto. Ah, ¿cierto? ¿Puedes tú buscar? ¿Qué dice color? Windows.
Good morning. My name is Cochlear Melendez. I'm a second-year resident of audiology, and today I'm going to show you to present an interesting case. Typical history is a 41-year-old male patient. He has a long history of smoking, and he was admitted to a 6-month gap with yellowish sputum and respiratory distress, and a weight loss of up to 7 kilograms in no time specific. On his arrival at the emergency room, he was reported a palpable testicular mass. So, because of the history of cough and of 6 months and the weight loss, CT of chest and abdomen was requested. In the left, we is the chest CT, and in the right, the thorax and abdomen CT. In the chest CT, we can see multiple pulmonary nodules with well-defined borders with the diffuse distribution, bilateral. The largest was in the anterior segment of the upper lobe, of the right upper lobe. We can also see a thickening of interlobal septa associated with ground glass areas, as well with telectasis of the right middle lobe. And when in the thorax and abdomen CT, we can also see multiple adenopathies in mediastinal adenopathies. The largest was in the the largest one was in the perihelial area, and also with multiple mediastinal adenopathies, and also in the cervical levels, and another finding is in the right testis. We can see that mass in the right testis with the it was oval image with partial defined borders in the left testis with enhancement with the contrast, and that was suggestive of a neoplastic process, and the findings of the chest with this another finding in the testis, we can also think that it was a metastatic disease. So this is a adenopathy that I was mentioning before. That it was in the perihelium. So with the finding of the testicular mass, testicular ultrasound was requested, and we can see in the left testis an evidence of oval image with well-defined borders, with echogenicity heterogeneous and predominantly hypoechoic with a Doppler color assessment, and it was suggestive of the formative process. We can also see the Doppler, the high resistance index, and with these all characteristics, the first thought or the first diagnosis that we think is a neoplastic in process in testicular in the left testicle. So. Left radical orchidectomy is performed, and the specimen is taken to the pathology department for the histopathological diagnosis. So in the histopathologic report, it was positive for adenocarcinoma metastasis with morphology and immunophenotype of the primary lung organ. So this patient, the lesion in the left testis was metastasis disease of the lung lesion that we see before. So after diagnosis, he received 3 cycles of chemotherapy with carboplatin and paclitaxel, and 2 months later, he was admitted with respiratory disease, fever, and hemodynamic instability. She developed cardiorespiratory arrest, and his relative decided not to perform resuscitation maneuvers, and she died in this hospital. Only 2 months later of the diagnosis. So the lung adenocarcinoma is the most common histologic type of lung cancer, grouped under the non-small cells carcinomas of the lung, and it was malignant tumor with glandular differentiation of mucin production expressing in different patterns on degrees of differentiation. And in this image is a single image of CT, and that it was performing a percutaneous biopsy, and shows the this lesion with ground glass image grounded, that it was adenocarcinoma in situ. The clinical presentation was like is very specific symptoms that early symptoms are fatigue with mild dyspnea, followed of chronic cough and hemoptysis at the large stage. This patient, our patient, it was a chronic cough of 6 months and weight loss of 7 kilos in this time. So in the radiographic features was commonly most commonly we find a lung in a rounded or irregular region in increased attenuation. We can further classify the nodule as in the either ground glass subsolid or solid nodule. Histologically, the ground glass attenuation corresponds to the lipidic growth pattern, and the solid component correspond to the invasive pattern. We can also see invasion of the main bronchus, visceral pleura associated with atelectasis in the tumors with more of the 3 centimeters, and we can also see suspect of malignancy with a nodal size of mediastinal node of more than 10 millimeters, and we can also see retropleural paraortic nodules of more of 8 millimeters. So in this case, the interesting was the site of the metastatic disease. The most common was in the lung, in the contralateral lung, or tumor with pleural nodules. We also saw the adrenal gland or the bone. So it's very important that in patients with a lung mass, check these areas. The metastatic tumors in the testes are extremely rare. The common primary site is a carcinoma of the prostate, and we can also study in the lymphoma leukemia, as may be found in initial manifestation of metastasis from another malignancy, like in our patient. The incidence of testicular metastasis from solid tumors in autopsy studies varies from 0.5 to 2.5%. Is like I said, is extremely rare. Among the cases of carcinoma that metastasize to the testes, the most frequent primary sites were, like I said, it was the prostate, lung, kidney, colon, and stomach. And the reason for the relatively low incidence of metastasis at these sites are unclear. But the most important reason was the relatively low temperature of the scrotum, which could be an unacceptable condition for the establishment of the metastatic tumor cells. The metastasis or the path of the metastasis in the from testicular metastasis from the lung cancer has been considered to be hematogenous, and because the peak of incidence of primary testicular cancer is between the second of the 4 decades, a testicular tumor in a patient over 50 years of age should be the first considered a possible should be first be considered as a possible metastatic disease, not a primary tumors, because it's not of the it's not of the group of age of considered the primary tumor of testes. So the conclusion of this case was that the presentation in this patient, how he has a respiratory symptoms. Also, he has a testicular mass. So the first suspect was the problem was primarily in the testes. So it's not. Let's see. It's very important to analyze all the clinic, the age of the patient that is not in the group of age that we can think testicular mass was the primary problem. So this is.
Good morning. My name is Ariana Michel Delgado. I am a 2-year radiology resident at Hospital Universitario in Monterrey, Nuevo León, and I will present you my interesting case. Okay, we have a 47-year-old female who arrives at the emergency department with weight loss and general malaise. Then a CT scan of the abdomen was requested for suspicion of neoplasm. This is the CT scan the day the patient arrived at the emergency room. These are 2 images of contrast abdominal tomography in arterial phase, and venous phase in axial images at the liver level. Here we can see in the liver multiple rounded hyperdense images in arterial phase that present washout in venous phase. These are generalized distribution. Here we can see in this image at level in minor sac the topography of the body and tail of the pancreas, and ovoid images with defined edges, heterogeneous, predominantly hyperdense, with areas of necrosis, with measure of 12 per 10 centimeters, which is causing mass effect in contacting more than 180 degrees the splenic vein and causing thrombosis of the same. The same findings we can see here in these images with this mass, large mass, heterogeneous mass. Now we will see some differential diagnosis based on the tomographic findings we have just seen. First, we have a pancreatic ductal adenocarcinoma. 90% of all pancreatic neoplasms and remains a disease with a very poor prognosis and high morbidity. On CT, it usually presents a hypodense mass that is poorly marginated, which may encase vessels and the common bile duct. We can see here how they enhance poorly compared to the adjacent normal pancreatic tissue. Another differential diagnosis are the pancreatic metastases. These are uncommon. Only 2 to 5% of all pancreatic malignancies. Enhancement pattern mimics the primary tumor. This is important. In case of hypervascular, the most commonly the renal cell carcinoma. In hypovascular are the lung, breast, colon, and melanoma. We can see here in this image an adultly enhancing pancreatic mass in a patient with a history of prior nephrectomy for renal cell carcinoma. The characteristic appearance for a renal cell carcinoma metastasis. And the final diagnosis confirmed by histopathology was a pancreatic neuroendocrine tumor, 2% of the pancreatic neoplasm, and they occurred most commonly at ages of 30 to 60 years with no clear gender predilection. The pancreatic endocrine tumors have commonly been referred to as islet cell tumors, referring to the islet of Langerhans, from which they were these tumors derive from ductal pluripotent stem cells, and endocrine tumor is now preferred. Approximately 2% are associated with the multiple endocrine neoplasia type 1, and there are also associations with von Hippel-Lindau disease and tuberous sclerosis. The clinical presentation in syndromic tumors tend to present earlier with clinical signs and symptoms related to their cell type and biological activity. Insulinoma present with Whippler triad, which consists of hypoglycemia, low fasting glucose, and relieved by IV glucose. And the gastrinoma with Zollinger-Ellison syndrome, and the non-functioning tumors tend to present late and offer larger in size. The CT findings in smaller tumors are hypervascular and tend to be homogeneous and well circumscribed, and in larger tumors may appear heterogeneous and contain areas of cystic and necrotic change. Can occasionally manifest as primarily cystic lesions and are indistinguishable from other cystic neoplasms by their hypervascular rim. The nuclear medicine play an important role in the staging of neuroendocrine tumors using gallium-68 DOTATAT PET-CT. In this image, we can see a hypervascular lesion with the proximal pancreatic body. And in this image, we can see an intense uptake of the gallium DOTATAT in the pancreatic body, corresponding to the hypervascular mass on CT. The treatment, we can use somatostatin analogs for symptom relief in case of syndromic tumors. The pancreatic neuroendocrine tumors with liver metastases, the resection of primary tumor may still have survival benefit, and the liver metastases treated with chemoembolization or chemotherapy if patient is not surgical candidate. The prognosis has much better prognosis compared to the pancreatic carcinoma, adenocarcinoma,
and excellent prognosis for insulinomas, which are usually benign but poor prognosis for gastrinomas. Non-syndromic tumors have a 5-year survival of only 44%, and the patients can live with metastases for many years. And that's all. Thank you.